Pleasure to introduce the first speaker, Dr. Martin Green from Canada, Professor of Medicine, University of Ottawa, Canada, electrophysiologist, University of Ottawa Heart Institute, Director of Arrhythmia Service, University of Ottawa Heart Institute. He will be talking about ECG for electrophysiologists. Dr. Green.
Thank you, Dr. Bukhari. Now, this was described a moment ago as a hardcore EP session. And I think I am a hardcore electrophysiologist, but I'm going to actually take you away from that. A recent, it could be an editorial, it could be a diatribe by Mark Josephson, described us as ablationists and defibrillationists. And I hate to say it, but I think he's probably got a point. I think we probably, it's important for our field to get back to the ECG, to get back to some of the basics. So I've entitled this talk, ECG for Electrophysiologists, From the Outside Looking In. And I've thought of that, and there's a double entendre there, but I think it's there for a lot of reasons. One is obviously the ECG looks from the outside in to the heart, whereas most electrophysiologists right now are looking from the inside out. That is, looking at their catheters and looking outward, whereas I tend to think that we need to start from the outside looking in. The second meaning, however, is that I feel like I'm on the outside now. I think electrophysiology and the field has evolved in such a way that Dr. Josephson is right. We do have some ablationists and defibrillationists, and we are, as a field, moving away from some of the basics. And I do consider electrocardiography to be the real basics of electrophysiology. And I think what I'm going to try to do today, it's a long introduction, but what I'm going to try to do is just try to convince everyone that we need to go back to the ECG, we need to go back to learning and looking at the ECG, and I'm going to try to just show you how the ECG helps us in our everyday work, and how maybe that will convince us all to spend more time thinking about it. So why back to the ECG? Well, SVT, VT, devices, blocks, and for fun. It's a lot of fun. We have a lot to learn from the ECG. So we'll talk a little bit about SVT first, and I'll just give you a couple of mild examples of where looking at the ECG can be helpful. So here's an ECG. This was from a loop monitor, a 52-year-old woman who complained of palpitation. And this was read as atrial tachycardia, some form of funny atrial rhythm, and basically, question mark, sent to me, what's going on? Well, I'm just going to show you the rest of that loop recorder, but the ECG, when you see a P wave halfway between two QRS complexes, you have to ask yourself the question every time, is there another P wave hiding in the QRS complex? And if you just move on with this, you see that just a few seconds later, these P waves, the rate suddenly doubles. And we see now what looks pretty much like typical AV nodal reentrant tachycardia. So this is, in fact, AV nodal reentrant tachycardia, here with 2-to-1 infranodal block, and here with 1-to-1 conduction. Well, if this had been the only run of it, the person reading the loop monitor probably would have got it wrong and probably would have missed the fact that this was AV nodal reentry. So why the ECG? Well, we need to make a diagnosis. We need to discuss the appropriate information with the patient before we go to the EP lab. And we need to allow for appropriate ablation target, for instance, if AV-NRT is not inducible. Sometimes you go in the lab and you can't induce tachycardia. It happens. If you have an ECG that is diagnostic, this may help guide you to appropriate ablation targets. So the typical, I've shown this one before, the typical ECG of AV-NRT with these little P waves in the terminal portion of the QRS complex, typical for AV-NRT. So you do your ablation, you ablate the slow pathway, and the nurse calls you a few hours later, 6 hours later, doctor, you've produced heart block. Uh-oh. You get the phone call. and you say something bad has happened, the patient has block. So you run up, because you don't like to hear that as an electrophysiologist, and you see this, and you've been called because there's a blocked P wave there. You think, so why the ECG? Well, now you put only the electrophysiologists seem to carry calipers nowadays. You put your calipers on it, and you find, in fact, that this is a premature atrial contraction. This is exactly what would have initiated AVNRT before, as it blocks in the fast pathway, but now there's no longer a slow pathway. So not only is this not bad, but this actually proves that the slow pathway no longer is capable of conduction. Why the ECG? This was a 78-year-old woman with palpitation all the time. Always had palpitation. I'm just going to blow up lead V1 here for you. And you can see, in fact, that this is sinus rhythm with a 1-for-2 response down the fast and down the slow pathway. And in fact, she was in a non-reentrant SVT due to dual AV nodal physiology. And she had constant palpitation. And we ablated her slow pathway, and that was many years ago, and she's loved me ever since. Here's a narrow QRS tachycardia. Well, if you don't look at the ECG carefully as we blow this up, we see that the sinus beats actually have wide left bundle. And I have many examples where the VT is narrower than the conducted rhythm. If you see a tachycardia where the tachycardia is narrower than the conducted sinus rhythm, it must be VT, even though it's narrower, because it's inconceivable that an SVT would conduct with a narrower QRS when the regular sinus rhythm conducts with a wide left bundle branch block. So this is, in fact, a VT that probably originates somewhere in the septum. Beware, narrow QRS tachycardias can sometimes be VT. Well, why the ECG? This was recorded on a monitor in the emergency room, described as a narrow QRS tachycardia. You have to look at the full ECG. This is the same rhythm strip. Here's the 12 lead. When they come into the emergency room and you only put them on, or someone only records one lead, that lead can look narrow. And yet this is clearly ventricular tachycardia. If we don't spend time asking the question, why do I need to look at an ECG? You need to look at an ECG for every tachycardia. Because in fact, this monitor strip would have fooled you. It would have fooled all of us, I suspect, and we would have all thought this was SVT, but in fact, this is clearly ventricular tachycardia. Wrong diagnosis, wrong treatment. You have to look at the ECG. You have to study it. It isn't narrow until you've seen the full 12-lead ECG. Another example, same thing, AVF in this case. There's the 12-lead ECG, clearly VT. And you can imagine that this could easily be diagnosed as being a narrow QRS tachycardia. It just takes the time to record an ECG and look at it. Okay, let's move on to VT. Well, Dr. Downer's going to tell us a lot about VT, but when we're going to, it's not just making the diagnosis. We have to actually consider where our ablation targets are. The ventricles are big. We have to know where we're going to look first. So let's talk a little bit about ablation targets in VT. We clearly need to be able to recognize what's an RV from an LV VT. We need to recognize in an outflow tract tachycardia, is it RV versus LV, or is it aortic cusp? And you'd better know these things, and the ECG points us the way. I don't have time to go into all of these, but here's a typical RVOT tachycardia with left bundle branch block morphology, a relatively narrow QRS, a late transition, positive in 2 and 3, negative in AVL, usually high RVOT, usually septal and usually anterior with this morphology. It points it to it right away. This is ARVC. I showed this at the last talk. clearly different, even though it's positive in lead 2, negative in lead 3. Free wall, right ventricle. Don't go into this thinking you're going to ablate an outflow tract tachycardia. This is an outflow tract PVC from the left ventricular outflow tract. In fact, in this particular case, from the left coronary cusp. And there are ECG algorithms to help us. This one published by Ouyang in the Karl-Heinz Cook group, of where we're going to find, where we're going to look for these things. And actually, the most surprising thing about this ECG, that continues to surprise me, even though I probably should have learned it 20 years ago, is that the right ventricular outflow tract is actually to the left of the left ventricular outflow tract when you look at it. So you have to know, you have to be able to, you have to study the ECG, you have to look at these morphologies, you have to know what to expect, you have to know where to look. Why the ECG? Well, it may actually help you plan your program stimulation protocol. This particular case, this was a young man. I showed this one yesterday, rock climbing. He kept coming in with this tachycardia. He'd had a previous EP study for which he was said to be non-inducible. And this is his ECG during sinus rhythm, and we see a narrow, incomplete right bundle with left axis deviation, identifying conduction system. This guy has a structurally normal heart, he has a normal echo, he had a normal MRI. He, in fact, had bundle branch re-entering VT. We took him back to the lab, and we did long-short stimulation. We took him back to the lab. In other words, the ECG helped us plan our program stimulation protocol, because this is not part of our typical VT stim protocol. We did long-short, and we induced his clinical tachycardia, and in fact, you can see